introduction, and thank you for the invitation to give this address from the co-chairs and from Tiikm. As Mr. Gamage mentioned at the beginning of the conference, we have a collection of government officials here, students, practitioners, conference organizers and officials, scholars and senior scholars. Now I look at the people he referred to as senior scholars, and they look very young to me. So I guess I'm in the next category. I'm not sure what you become after being a senior scholar. But that I'm afraid is what I am. So I'm going to talk about the work I've done over the past 2 decades in both obesity, childhood obesity prevention, and mostly in the San Diego area, and then in dengue prevention and control in tropical countries around the world. And it's been nice to have these two types of activities going on, because I always felt that they inform each other, and I keep trying to think, well, what am I learning from dengue that can inform my obesity work, and what am I learning from childhood obesity prevention that can inform my dengue work? So I'll try to share some of that with you, and we'll see if it makes any sense to you. If not, you can write something on the program comments, I guess. Traditionally, we have had a distinction drawn between infectious diseases and chronic diseases. But more recently, there's, of course, infectious diseases that have long chronic phases. That includes HPV infections that result in cancer, HIV infections that can be controlled over a long period of time, and tuberculosis. These have very long chronic phases, even though they are infectious diseases. But generally speaking, vector-borne diseases such as dengue and malaria have been left out of this type of classification. They are seen as a separate form of infectious disease that really did not have the same sort of connection with chronic diseases. So more recently, we have been more specific with our classification of chronic diseases. Either it's an infectious chronic disease or a non-communicable chronic disease. And most of you are familiar with this process here, going from the risk to asymptomatic and symptomatic phases, to treatment, and then ultimately to remission or relapse or cure or control. But in terms of vector-borne diseases, we have seen some success, as was pointed out in the conference co-chairs. I think it was Dr. Ben Norton that talked about the successes in malaria control. This is true. Nevertheless, the mosquito remains a very dangerous creature, and it's National Geographic pointed out in an issue dedicated to this danger. It's the most dangerous non-human animal on Earth. We think about snakes, we think about scorpions, we think about wild dogs and all sorts of things like that, I guess. But it's the mosquito that really is the most dangerous in terms of mortality. And then if we look at obesity, in 2010, this is remarkable to think about in the change in the world. Obesity passed hunger in terms of its threat to global health. And this is stunning to think about, but calories have become cheap, and it's the one thing that poor people, even the poorest people, can usually afford is at least to get enough calories. Now they still may be stunted and malnourished, but they do have calories, and they can become obese. 2 billion people in the world are overweight or obese. And it's estimated by the recent Lancet issue that this accounts for approximately 5% of global mortality. So, a simple depiction of the vector-borne disease process. Again, this is the traditional depiction where the agent is a virus or bacteria. The vector is usually an insect, but it could also be a bird or rodent, or it could be a dog. It could be a variety of different species. And then the host is the human that gets infected. And this is still the standard model for vector-borne diseases. But what we're finding out in dengue, and I think in malaria and other issues, is that it's a little more complicated than that. So for dengue fever, you start off with a mosquito that's actually not carrying the virus. So is this a vector? Well, not quite. It's not really a vector yet. What happens is this mosquito bites a human, feeds on a human's blood that is carrying the virus. So even though this human is a host, it also is the person who infects the mosquito, if you will. The agent then, the dengue virus, is carried forward by this mosquito, who becomes the vector. And it's not until this point really that the mosquito is the vector. But then look what happens. This vector then, this mosquito, now infected in herself, this is a woman mosquito, bites another human, and that person who then is infected and becomes sick can then infect new mosquitoes. So in a way, even though this poor person is a host, she is also a vector because she's spreading the disease to new mosquitoes. Now let's look at, I'm trying to force a vector cycle process on obesity onset and obesity prevention and control. So the agent, energy imbalance. That's usually the agent. There are genetic factors and other things, but usually the agent is energy imbalance. So it's calories consumed and balanced by energy expended through physical activity. Vectors are other people. They could be role models, parents, people who either are promoting healthy or unhealthy lifestyles, but also who are promoting fast food through advertising, maybe buying televisions or electronic toys for their children who spend much of the time screen time. Trying to walk across campus at my university in San Diego, I have to walk like this because so many students are on their cell phones that they can't see you, of course. Sometimes I feel like just bumping into them, but they're quite a bit younger than I. Then the host is the child who's maybe not able to monitor calories, or maybe is, consumes fluids, either sugar-sweetened beverages or water, and is sedentary often, or engages in some physical activity. Then the healthcare system has an important role, and since one of the emphases of this conference is on healthcare, I'm going to be spending more time on that. So we have well baby checks. This is a universal thing in developed countries and developing countries. There are well baby checks, height and weight monitoring, all of that. But seldom does that well baby check or well child check include an obesity check. If you're on the growth chart, if you look at the growth chart, you're only concerned if you're under the line for height and weight. We seldom look at the child who goes over the line, or at least the physician or the nurse does not say anything, or the community health worker. So let's see what these two vectors have in common. These two health challenges. Well, excessive consumption. This is a lot of trash is responsible for dengue breeding, for mosquitoes to lay their eggs, because this collects rainwater, and the Aedes aegypti lays its eggs in there, and these grow in the trash, and this is very common. Now, the excessive consumption, obviously, in food, that's fairly easy. This is right around the corner as you're walking around on this main, Sukhumvit, I think it's pronounced, on the main road right here, right outside the hotel. You'll see this special burger place that advertises, seriously, that you could have burgers, ribs, brisket, beer, and heart attack. It's right on their sign. You go out and see this. So they're not even, I give them an award for truth in advertising. This is fantastic. Okay, so excessive consumption is one thing that the two disorders have in common. Multiple diseases that stem from the Aedes aegypti or obesogenic genicity. The Aedes aegypti can spread dengue, yellow fever, but also West Nile, chikungunya, Eastern equine encephalitis, and Zika. Zika scare was really big 2 years ago. It's calmed down now some. Obesity, all kinds of chronic diseases are caused or contributed to by obesity. And in the United States, we project that 75% of our healthcare costs, 75% of a very expensive healthcare system, spends its money on obesity-related problems. This is one additional issue, social isolation, where an obese child is more likely to be bullied or lose friends or not have friends. Although that's, since more and more children are becoming obese, that's become, ironically, less of a problem. There's a vertical transmission issue. This is clear not in dengue, but in Zika, where it's vertical transmission that does spread the problem. The mother herself will have a brief illness. It's a rash. It's not that bad, but if she's pregnant, the microcephaly could easily result in the child when it's born. Now, recent research has also looked at vertical transmission in obesity, where where diabetes and obesity may be spread from a mother who has diabetes or who has too much weight gain during pregnancy. So there's a clear implication for the healthcare system, because it not only directly transmits this somehow through the umbilical cord, but there's actually maybe even epigenetic changes that result. Okay, so also what they have in common is a global spread, and hence my title, Diseases Without Borders. These diseases know borders, no borders whatsoever. Now, when I was an assistant professor in 1960, there were only a few countries with that had a lot of dengue. And it was here in Southeast Asia, Venezuela, and not many other places. It wasn't reported as widely then, but there was not much dengue worldwide. And you can see now the very great spread of it, and not just to areas that are tropical, but even a little bit subtropical or moderate climates. Now, these are boys only, but the map would be the same for girls. This should be obesity and overweight prevalence, not just obesity. So, but you can see that it's not just the United States. Actually, Mexico has surpassed the United States. Southern South America is catching up. China, Australia, much of Europe, much of Northern Africa and the Mideast, and then less so perhaps in equatorial Africa. We can see, though, that this is a big change. These are a lot of these nations here were suffering from malnutrition as recently as 2 decades ago. And when calories became available at an inexpensive level, there was an explosion of obesity in a lot of these countries. So the rate of growth in developing countries in obesity is much greater than the rate of growth in the so-called Western or industrialized countries. Okay, so what do we do about these things? Well, policy, technology, and communication through health services and through other agencies. So vaccine development is still underway in dengue. There are some nations that have tried this on population basis. It has not been shown to be effective enough to be fully promoted internationally. In terms of controlling the vector, typically we use larvicides, control of breeding sites, trying to eliminate them or get water out of them. Aerial spraying, simply flying over an area with a helicopter or airplane and spraying for insecticides. And recently there's been some research in genetically modified mosquitoes which cannot reproduce. So they will mate, but the eggs will not develop. In terms of what we do for the host, well, that we can offer personal insecticides, indoor spraying, nets and curtains, and symptom monitoring. Now, personal insecticide, most people here probably use it at times if you're in a place where there is a lot of mosquitoes or other biting insects, but it's still an expense factor. Indoor spraying, somewhat less common, but a lot of retail, hotels, other places will use that, and to some extent homes will do that too. Insecticide-impregnated nets and curtains have shown some promise. And symptom monitoring, trying to find a person early who has the symptoms of dengue or malaria or whatever, and getting that person isolated and under control. Much more difficult to do because by the time you detect these symptoms, the viremic levels are down and they're not infectious. And then health care. Well, mostly what health care does is palliative care. A person with dengue comes to a health center, they've had it for a few days, and they're given something to control the fever, perhaps to control the aches in the joints and things like that, aspirin or something. Isolation of high viremic patients, well, that would be a health care task, but it's it's very difficult to do because we don't know when they're high viremic. It's before they come to the clinic. So, and then early detection. Now again, these first two steps, early detection, isolation, are very difficult to do because the healthcare system is in a clinic. It's waiting for people to come to it. They're not going out into the villages or into the neighborhoods to check this. So it's mostly palliative care. In terms of childhood obesity, the agent is usually moderate to vigorous physical activity, MVPA, or conversely sedentary activities. Moderate to vigorous activity keeps a person thin and fit. Sedentary activities contribute to obesity. Purchasing and preparation of foods. We either buy healthy foods and we prepare them in a way that keeps them healthy, or we buy foods that are low in nutritional value, and we prepare them maybe with fat or or in other ways that make them even worse. In terms of taking on the vector, well, advertising restrictions. This is very controversial. This is very difficult to do. In the United States, it's very political. We have tried to do this, and you may have heard of Mayor Bloomberg in New York, who banned the advertising and then eventually sales of large Coca-Colas, and the entire USA was up in arms, angry at him for doing that. Fast food menu options. Some fast food outlets are saying, wait a minute, we don't just sell heart attack burgers, we have salads too. Usually the salad has some dressing with it that is 1,000 or 2,000 calories. Calorie posting. Now, I don't know how many countries do this, but in California, you have to, if you have 5 outlets in a chain, for instance, McDonald's had thousands, or Burger King has hundreds, and but you have to, on the menu, you have to put the number of calories next to the menu item. I think that's a good idea, actually. At least the population knows what they're getting. And parental control of screen time. This has been a big problem for us. We talk about cheap calories, but we also have cheap screens. Televisions worldwide have become inexpensive. What used to be, in my career, I would go to South America in small villages or even in small towns, and everybody would be clustered around a store that sold televisions so they could be watching a show because they couldn't afford this themselves. We have people in our poorest neighborhoods in San Diego who buy their children their own personal television for Christmas so they can have it in their room and watch the shows that they want to and never have to move. So the host, well, the host then ends up with low-fat, nutritious food or fatty. Well, if we're doing these things correctly, they should have a lower fat and more nutritious food. They should be consuming more water. This is a very simple behavior we're trying to promote in our obesity control program. And more participation in sports or physical activities. There's something in the USA called the American Youth Soccer Organization, which is a non-competitive soccer teams are put together, boys and girls, separate teams. But these are leagues that are put together where all children play. And soccer or football, as most of the world calls it, is becoming much more popular in the USA because it is something that all children can play. And we're changing from what we used to have in terms of American football and baseball, which are very sedentary or even dangerous sports, to a much more active and healthy sport. Okay, healthcare. Well, pediatric screening, again using a growth chart or something similar to that for watching child weight gain and following up on child weight gain can be very useful. But this is seldom the case. Pediatricians are reluctant to do this. We'll talk more about that in a minute. And increasing parental awareness, talking to the mom and dad and saying, okay, you need to keep track of little Johnny's or little Sally's weight because she's getting heavy, and so you need to just monitor it, see what they're eating, make sure they get some walking in or some exercise. Okay, so what works? Well, I hope I won't have time in this presentation to go through each of these tables. I hope the journal will allow me to put them in and give me enough room, maybe some extra room in the publication. But what I like to use to evaluate our programs, because it gives us a common framework, is the REAIM model for determining or for program evaluation. developed by Russ Glasgow and his colleagues. This is not a perfect model. There are other good models out there. It's just the one that helps me compare things like dengue and childhood obesity. Okay, RE-AIM. What does it stand for? Reach. The percentage of the target population that is reached and affected by a program. Effectiveness. What are the primary outcomes per person, groups, and population? And are those outcomes maintained, or what is the attrition and relapse rate? Adoption. Now, this is the percentage of settings that adopt a program. It's not the same thing as reach. Adoption is, does a clinic or a hospital or an entire community or a school adopt a program and maintain it? And again, this is a problem. I've had a lot of promising obesity and smoking prevention programs started, for instance, in schools, but as soon as our funding runs out to see that they've been effective, the school drops the program. They go back to something else. Implementation. How much does it cost? We talked about cost effectiveness earlier in the introductions. What's the consistency of the implementation? And how complex is the program? That's a big issue. It's something I added. And how much can we tailor a program to an individual community or an individual country? And maintenance. What is the long-term impact on people and maintenance of programs? Well, for this conference and for the journal issue that will come out after, what I've done is I've looked at both dengue and childhood obesity and the different factors related to the vector disease process and broken this down. So evidence for reach, you can see I'm looking at evidence for controlling the agent. Vaccines are largely in the testing phase, and even if they are developed, they're going to be expensive. The vectors, genetically modified mosquitoes, spraying, things like that, we don't know about. Either they're not effective, or they're effective for just a short time, or they're still in a research phase. The host varies with individual respect to knowledge, but early symptoms are difficult to differentiate. You don't know if you've got dengue. You don't know if you have malaria. You may just have the flu. And then finally, health services. I'll focus on these just to get through these more complex slides. But the responsibility for dengue diagnostics, prognosis, surveillance, and vector control, as well as, if they come online, vaccine use of vaccines, will be the responsibility, or usually the responsibility of health services. The reach is limited, though, because the patients need to come to the clinic. They need the physicians and the nurses are not going out into the streets. They don't have enough time. They don't get paid to do that. That's not what they do. Okay, so I go through these same things with then childhood obesity. All primary care providers, all pediatricians, nurses, etc., they know what causes obesity, and they know how it can be controlled. So there's not a problem with the reach there. Effectiveness, let's just go to health services. Health services are effective at treating most acute illnesses if a child is brought to the clinic in time, or at least given sufficient palliative care to get the child. Okay, for maintenance, the good thing about dengue is patients typically recover. It's seldom fatal, and not only do they recover, but they develop immunity from that strain of dengue. Now, there are 4 strains of dengue now, so you can be reinfected, but it won't be with the same virus. Okay, and we have all the things that I'm supposed to mention, and I know they're not remembered. So energy balance is really a complex thing, especially if you're not counting your steps, and you're not reading labels, and you're not measuring portion size. If you have a piece of hamburger, you can say how many calories that is, perhaps. If you have a lasagna or a spaghetti bolognese, you don't know how many calories because it has many things in it. So that's very complicated. Container control is also very complicated. If you have to scrub, use larvicide, dump your animal dishes every day, you have to do all of these things, and you have to convince your neighbors to do the same thing because it's not helping you if you're the only person doing it. It's a very complicated thing. So, it's the KISS principle. KISS stands for Keep It Simple, Stupid, and that's what we encourage people to do. So what I'm doing in my current work in obesity is I'm trying to get away from obesity. I don't care about obesity. It's genetic, it's all sorts of things. It's maybe for vertical transmission. Drink water and count your steps. 2 things. And if you can do that, even if you get big, at least you're healthier in other ways. Okay, these are some of our newsletters. I'm almost embarrassed, but we tell our parents. These parents maybe have 6th grade educations or not much formal schooling, certainly no university schooling. And we're telling them all kind of things to do and just different activities. We tried to make these good newsletters, but I'm sure they were thrown into the trash because they were just too complicated. Public perceives benefits differently than health services do. So, if I can put if I could do indoor spraying, let's say, and I can kill cockroaches, that will sell to people. They like to see dead cockroaches. They sweep them out. They hate them, and it's a nasty-looking bug. If I'm just killing little tiny mosquitoes, they don't really care about that, or it's not something they're going to do a lot. If I can sell somehow food that tastes good, then that's one thing. But telling them about HDL and total cholesterol ratios and that sort of thing doesn't interest people. It's somewhere in the blood, they can't feel it. They say, okay, well, that's enough for that, I'm going out to dinner. The healthcare system, the third lesson, is critical at all stages of prevention. But their emphasis is on cure and care, control second, and prevention last. So we need to get physicians out of their comfort zones. And by that I mean we need to get physicians and nurses and other primary care providers to say your child is gaining too much weight. And I'm going to check on that. Now, how we do that without the mother killing that physician, I don't know, but that is at least research that's worth doing. We need to get physicians and nurses and other people to ask individuals, parents, and others who come into their clinics what their household condition is like. Do they use indoor spraying? Do they use insecticides themselves? Do their children sleep under bed nets? Do their pregnant mothers sleep under bed nets? And keep asking that. Do their neighbors cooperate with them in breeding site control? This is not something they're comfortable with. So again, we need to get the health services out of the comfort zone. You've got such and such disease, it's caused by such and such. Here's an aspirin. Here's a pain pill. I don't know, you have high blood sugar, high blood pressure. These are pills for that. Okay, but the health sector, health services needs incentives. One of the best incentives we found was that the community expresses gratitude that they're seeing the physicians and health workers out in the community. But they also they work for money, and the community needs to know that providers will follow up with them, that they really do care about these issues. They ask, boy, he keeps asking me about my cigarette smoking. I guess this is really an issue. A lot of physicians will say once or twice, you shouldn't smoke, then they give up. It doesn't work. Evidence shows that if they ask 10 or 15 times, the person will try to quit smoking. But it's again, that sort of persistence. But health services can't do it alone. Now, we can't blame health services. There has to be joined forces with sanitation departments or ministries sometimes, city planners, policy experts, technologists, researchers, schools, and even the commercial sector. Sometimes the commercial sector is part of the solution. Often they're part of the problem, but at least we have to have them at the table. So here's an example of the use of incentives and showing the community that the health services cared. This was a lot of fun. This is that same community in Johor Bahru in Malaysia. We had container control program that included getting all the trash out of the streets. There's a lot of trash, high levels of consumption, fairly middle class community, I would say. So what we did, or I didn't do this, it wasn't my idea, but I got to see it and it was wonderful. Once a week, they would have a lottery for trash pickup. And children would get one lottery ticket for a bag or a small bicycle tire. They would receive a lottery ticket. If they brought in a big tire, sometimes these tires were bigger than the children, they would get 5 or 10 lottery tickets because these hold a lot of water. This was so brilliant, and these children were so excited. You can see them then waiting for their numbers, and not all of them won. But they kept trying because they knew that there was a chance, especially if they were bringing in the big stuff, that they would get a lottery ticket. So it was a good way, a fun way, to show that the community was taking this seriously, the health services sector was taking it seriously, and yet, and a good way to get children involved. Often in dengue programs, vector control, we do posters, we do little puppet shows and stuff like that. That's nice. There's nothing wrong with that. But these are actions. These are activities that actually can help. This is in Guatemala. This physician went way out of his comfort zone and said, we have to do something about dengue. So he got the mayor involved and the vice mayor involved, the head of the Rotary Club, one of the wealthiest people in town, the head of the sanitation department. And this is an indoor spraying machine that they were also proud of because they raised money to buy these, enough to spray indoors on every house in Kuala, Guatemala. But it was because of this physician that this was organized. Here's an example of city planning. Now, you may recognize this. It's right outside the hotel in Sukhumvit. These people here are not getting any physical activity. Maybe just a little bit where they dodge with their motorcycle, I don't know, but not much. People running across the road are getting some, but they don't go very far. Right above here is the SkyTrain. These people also, and here's taken from my hotel room window, and here's from the street. These people are not getting physical activity either, but at least when they have to walk to the SkyTrain and then walk up the steps to the SkyTrain, they get a lot of physical activity. And then when they get off the SkyTrain, they have to walk somewhere else, maybe 5 minutes, maybe a half an hour. But it's much better for them than sitting in this, and much better for the city too. So there's an example of how city planning can work with us, and we can promote what they do as well as they can help us. Okay, so research for program development needs to be multidisciplinary. There is no way that one group of researchers can take these things on. And a good example is my colleague, Dr. Tom Scott from the University of California, Davis, has organized a dengue research team in Iquitos, Peru. It's on the Amazon River in Peru, South America. And in this research team from 6 different nations around the world, we have entomologists, biologists, epidemiologists, behavioral scientists, geographers, ecologists, demographers, and mathematicians. It is so much fun to be in a room because it's like the Tower of Babel. You have to learn to speak other people's languages. You have to translate into your discipline. And we can all contribute in our different ways. It's the best learning experience I've ever had being part of Tom's team. And finally, programs need to be tailored to the resources and culture of individuals in their communities. So, Laos, neighboring country, very poor country. So this is part of the WHO dengue container control program. A big problem was coconut shells. People buy coconut for a snack. They drink the juice. There's a straw there. They just throw the coconut on the ground. Now, there's nothing wrong with that kind of trash. It's biodegradable. It's natural. The coconut would eventually fall down anyway. So there's nothing wrong with that kind of trash, but it's a perfect receptacle for Aedes aegypti breeding. Now, the only way to do anything about that would be collect all these thousands of coconut shells and burn them. And that's just kind of crazy. We also try to get people to control their tires, to use tires. This one guy, he was only about this tall, an old man, he took a knife, a really sharp knife, and he took his tire and cut all the way around and split it in half. It's not a very good picture, unfortunately, but it took him all day to control his tire. He didn't want any water standing in his tire, so he cut it in half. That's not a sustainable type of behavior. So indoor spraying really was the only answer for this community. And Laotians are not going to give up their pots, as they have these clay jars all over for decorative purposes, for functional purposes, for water storage, for plants. So they did accept putting fish. Some people accepted putting fish in there that would eat the larvae and eggs when they were laid. And other people accepted a drip system, which kept the water moving. And then the egg would not grow because they could not attach. So this was something that, notice this is quite a bit different than the Malaysia campaign, where Malaysia, being a wealthy country, has a lot of resources to do other stuff. Laotians don't have those resources, so we had to find more practical ways to do this. And we have to brag about people who adopt the behavior. We have to reinforce them. So this is in Managua, Nicaragua, which sadly has been in the news way too much lately, but we were doing a container control program, and community health volunteers went door to door to look at containers and make sure there were no Aedes pupae or larvae in the containers. And they filled out a report card for the homemaker, usually the housewife, who lived in the house, and she had perfect marks, and she was so proud of this. And she had a picture of Jesus on one side, and her grandchildren on the other side, and her report card was right in the middle. So she was just very, very, very proud of being of receiving these high marks, but also expecting, just enjoying the visit from this health worker in her own home, welcoming her and saying and appreciating that she was being reinforced. Okay, so a last thought then. Humans are vectors too, even in non-communicable chronic diseases. Dr. Fowler at UCSD, a colleague of mine, has shown that An individual who's overweight, who joins the friendship group of thin people, will become thin. An individual who is underweight, who joins a friendship group of overweight or obese people, will become overweight or obese. So humans are vectors too. We don't know all the mechanisms. It's not as clear-cut as a mosquito, but it is true. Humans are certainly vectors in the malaria and dengue process. And they don't have to suffer from the vector themselves, from the disease, to be a vector. So we need health services to target these people as well. A few references, acknowledgments from many colleagues, Tom Scott and others, for dengue, Noe Crespo and Suchi Ayala, and others for obesity work I do. Just so many others in many very different disciplines who I've worked with over the past and learned so much from. And so, that's it. Thank you very much.